We will go ahead and get started. Good afternoon, everyone. My name is China Locklear. I'm a project coordinator at the National Indian Health Board, and I will be moderating today's session. I'm really excited to have our panelists here today, Dr. Ronnie Bell, Mary Beth Cox, Ginger Parker Southard, and Alyssa Kitlis, presenting today on understanding and addressing opioid and substance use among American Indians in North Carolina. I don't want to take up too much of the presenters' times, but I do want to make a few announcements. I do believe this webinar is set up like a panel, so if you can't see yourself, that's why. We're going to set aside about 10 or 15 minutes towards the end for the panelists to take questions, so you can do that in the Q&A portion down at the bottom or in the chat, or you can use the raise your hand function below as well, and then we will allow you to speak that way. So I'll go ahead and turn it over to the panelists so that they can take as much time as they need to get through their presentation. Thank you.
Thank you, China, and thank you all for attending today. Thank you for the work that you're doing across Indian country, and thank you for your interest in this topic. So this is, as China said, is a tag team effort, and so you're going to hear from several of us today who have been working in different spaces in the area of opioid and substance use among American Indians in North Carolina. I am Dr. Ronnie Bell. I'm an enrolled member of the Lumbee tribe. I'm the chair of the North Carolina American Indian Health Board, and I'm also a professor in the Department of Social Sciences and Health Policy at Wake Forest School of Medicine. So today, next slide, Mary Beth is going to be controlling our slides today. So this is the outline of our presentation. So I'm going to start with just an overview of American Indians in North Carolina, for those of you who don't know. And then Mary Beth will talk about some of the data looking at overdose among American Indians in North Carolina. I'll come back and talk about the collaborations that we've established with the Injury and Violence Prevention Branch to address some of the issues around opioid and substance use. And then you'll hear about two innovative programs in North Carolina, the Syringe Services Program and the Zollie Syringe Service Program at the Eastern Band Cherokee Indian Reservation on the Qualla boundary. And then hopefully we'll have enough time to answer any questions you might have. Next slide. So this is me, and so if we were all together, I would do a traditional land acknowledgement, and since we're not, I will just recognize and pay homage to the American Indian people who live in North Carolina, but also our ancestors who have occupied what we now know as the state of North Carolina for at least 100 centuries. We have 8 state and federally recognized tribes in North Carolina, the Eastern Band of Cherokee Indians, which is the only federally recognized tribe in the state, and is the survivors of the removal process that led to what we now know as the Trail of Tears. Then we also have in the southwestern part of the state the Lumbee, the Waccamaw-Siouan, and the Coharie. In the northeastern part of the state, the Meherrin and the Halawa-Saponi, and the north central part of the state, the Saponi and the Occaneechi Band of Saponi Nation. Next slide. So North Carolina has a relatively large American Indian population compared to other states in our country. We actually have the largest American Indian population in the eastern United States. I think the most recent 2020 census estimates indicate that about 300,000 North Carolinians identify as either American Indian alone or in combination with another race or ethnicity, and about anywhere from 1.2 to 1.8% of the North Carolina population identifies as American Indian. Next slide. What we do see in North Carolina is what we see across the country is significant health disparities across the board, and a lot of that is driven by the adverse social determinants of health. And so if we look at factors like the percentage of the population with a high school education. We look at unemployment rates, poverty rates, rates of uninsurance, again, recognizing that only one of our 8 tribes is federally recognized and has access to Indian Health Service healthcare, and disability rates. All of those are significantly higher for the American Indian population compared to the non-Hispanic white population in our state. Next slide. And so this manifests itself in not only mortality and morbidity rates that are unacceptably high for our American Indian population, but also in rates of risk factors for these chronic conditions. So factors like obesity rates, rates of self-reported fair or poor health. At least close to 50% of our American Indian population has 2 or more chronic health conditions, and we see almost a quarter of adults use tobacco in a harmful manner. Next slide. And then as we look at some of the manifestations of that, so we see high rates of heart disease, of stroke, of cancers, of diabetes, but then we also see some of the adverse effects as it relates to motor vehicular accidents, as well as homicide rates that are unacceptably high for our American Indian populations in the state. So I'm going to turn it over to Mary Beth to talk about some of the data that the state has looked at as relates to overdose and its impact.
Thanks, Dr. Bell. Can you all hear me? Great. Hi, everyone. I'm Mary Beth Cox. I'm a substance use epidemiologist with the Injury and Violence Prevention Branch within the North Carolina Division of Public Health. And like Dr. Bell said, I'll be sharing some of the data work that we've been doing around this population. So this is probably not a surprise to anyone who is on this call or pays attention to the news at all, but CDC sent out a press release last year announcing that we reached over 100,000 overdose deaths nationwide. This is really in that first year of the pandemic, estimated 39% increase that we saw in drug overdose deaths. And North Carolina experienced a similar increase. We saw a 40% increase from 2019 to 2020, with 3,304 North Carolina residents dying of a medication or drug overdose death. And this is after seeing the first decrease that we had seen in over a decade. In 2018, we had a slight decrease, and then in 2019, kind of the numbers started to stabilize. But we know that this population, individuals who use drugs, are heavily impacted by COVID-19 and continue to be, which is the unfortunate trends that we're seeing continuing on into 2021. It takes a long time to finalize death certificate data, especially for overdose deaths. They take a lot of investigation, toxicology, autopsy. There's a lot that goes into kind of processing the death certificate for these individuals. So we look to our emergency department data. In North Carolina, we're fortunate to have a really timely system. And we also are looking at our provisional death data, and both of those sources are pointing to continued increases in overdose death and ED visits in 2021. And then finally, kind of setting the stage for the epidemic in our state. Like many states across the nation, this epidemic is now driven by illicitly manufactured fentanyl, but we're also seeing significant increases in overdose deaths that involve stimulants like cocaine and methamphetamine. And we're seeing a growing number of these deaths involving multiple substances in combination. So this is what we refer to as polysubstance use. And I do want to note that we're not able to tell from death certificate data, emergency department data sets, whether or not that polysubstance use was intentional or not. So someone may have intended to use multiple substances at the same time and it resulted in their death. Or they may have purchased cocaine. They're historically a stimulant user, and then there was fentanyl laced in that cocaine, and they didn't realize they were using an opioid. So there's intentional and unintentional polysubstance use, and we can't decipher that in the data. So moving on to this population in particular and how this work kind of came to be for our branch and our work in injury and violence prevention. This started several years ago. We were a much smaller shop at that point in time. It was myself and one other epidemiologist focused on the overdose epidemic. We've thankfully grown over the years and have more help to do more in-depth analyses. But at the time, we had a colleague who went out and presented to a local coalition, and she received a question from an audience member who said, I hear in the news all the time that the overdose epidemic is a white problem, that it's only white individuals who are overdosing, particularly white males. Is that true in North Carolina? And my colleague didn't know the answer. So she came back to our team of epidemiologists and asked if it was possible for us to start looking at the numbers and kind of doing that stratification by race and ethnicity and different demographic groups, because at the time, we'd really just been tracking statewide and countywide numbers year over year and not really diving deeper, which was doing a disservice, I think, to the people of North Carolina. So want to do a quick little like Epi 101 lesson here. And folks might be familiar with the importance of looking at rates instead of just looking at counts, but just to kind of illustrate this, you're looking here at year over year counts of medication or drug overdose death. The lighter blue bars on the left here, these are for non-Hispanic white residents in North Carolina. So in 2000, there were 401 deaths, and then over 2,400 deaths in 2020 among non-Hispanic whites in our state. And then these darker blue bars, some of which are so small, you can't even see them on this figure, but these are the same counts for American Indians in North Carolina. So 7 deaths in 2000, and in 2020, that increased to 104 deaths. So if we were to just look at the counts, then you might say, yes, this is primarily a non-Hispanic white problem. However, when we standardize for population in our state and look at the rates per 100,000 white population per 100,000 American Indian, we see a much different story unfold. And so back in 2000, both non-Hispanic whites and American Indians in North Carolina had equal rates of overdose death at 7 per 100,000. And then you can see over time, American Indians actually have rates that are similarly high, sometimes even higher, and in these more recent years, much higher, especially in 2020 with those impacts of COVID-19, we see much higher rates among our American Indian population. And just a few more data background slides I wanted to share. So in that entire 20-year time frame, looking at all race and ethnicities in North Carolina, American Indians still have the highest rates of overdose death, followed closely by non-Hispanic whites, and then non-Hispanic Blacks, Hispanics, and Asians all having lower rates of overdose. But it's still really important with these other populations that we're also paying attention to how quickly the rates are increasing. And I'll talk a little bit more about that on a slide towards the end. Just sharing another layer of that kind of data analysis that we kind of make regular practice now, but this has not yet been updated to include 2020 data, but I still wanted to share the differences in population here. So we're looking at, on the right-hand side, the lighter blue bars, these are rates for overdose death rates for males and females in the total population in our state, and then the age breakdown. The left-hand darker bars are for American Indians in North Carolina, and you can see similar age ranges that are really impacted regardless of total population or the indigenous population. That 25 to 54-year-old age range is really what we see most heavily impacted by overdose. When we look at male and female, we saw a different story play out among the American Indian population, where typically we've talked about the overdose epidemic as being predominantly male, and that men tend to have rates twice as high as females. And you can see that's true in the North Carolina overall population. But when we look at just American Indians, female American Indians have rates that are almost as high as their male counterparts and much higher than what we see in the overall state population. So just hoping to drive home the importance, if you're someone who is looking at data or has access to data, analyzing it, of really stratifying by all those different combinations so that you can kind of get at who is disproportionately impacted by these epidemics. And then quickly wanted to share another disparity that we've been tracking with our colleagues at the communicable disease branch. These data are older. The folks who report these data and do the investigations on acute hepatitis B and C infections are the same folks who also have been doing all of the COVID-19 response. And so data are just heavily impacted and delayed. But we do see that disparity, especially in acute hepatitis C infections being much higher in North Carolina among the American Indian population. If you were looking at trends over time, these are increasing kind of for across the board for all of our populations, but especially high in American Indian populations in North Carolina, likely due to injection drug use. And then just to wrap up, I wanted to talk a little bit about our opioid and substance use action plan and the data dashboard that accompanies this plan. So this is our statewide action plan that has several different strategies to kind of move the needle on the overdose epidemic. And it was most recently updated to include this center strategy. And this is the idea that we are trying to center equity and lived experiences in all of the work that we're doing to combat the overdose epidemic. And so for me as an epidemiologist, the work that I do kind of lives in this outer ring where we're also trying to always track our progress and measure the impact of the actions that we're doing. And to include equity in that tracking meant that we've tried in all of our data products to have a health equity focused lens and look for those disparities and share them with our partners who are actually on the ground doing this work. And so you're looking here at a newer page that we've added to the dashboard to talk about the importance of this equity focused lens and looking for disparities, and also look at the rates by different racial and ethnic groups in our state. We also put out earlier this year press release talking about that 40% increase that we saw in 2020. And it included this table here that looked at 2019 and 2020 rates of fatal overdose among American Indian, non-Hispanic Black, and non-Hispanic white populations in our state. And I alluded to this earlier, but we also included this percent increase comparing the 2019 to the 2020 rate to try and draw attention to the fact that especially for the non-Hispanic Black population, their rates are lower than non-Hispanic whites and American Indians as well, but they are increasing faster than our white population in the state. And then of course, as we already pointed out, that significant increase that we saw in 2020 among the Indigenous population with a 93% increase between these two rates. And we have tried to take that same table structure. When that press release went out, we saw several media outlets pick that table up and create their own data visualizations and share that information. And as an epidemiologist, that makes me really happy to see people interpreting the data appropriately, understanding it, and putting it into their own words and dissemination to partners, because that's how we spread the word about these problems and disparities. So we mimicked that same table setup. Here we're looking at the rates, also the counts, so we understand the magnitude, and then how quickly are these increasing, and also added, this is a screenshot from our dashboard, but added the figures as well. And what's really great, I think, about this is that the thickness of the line is proportionate to the number of deaths. So you can see this thicker line, there are more deaths for non-Hispanic whites. However, this thinner line for American Indians, though getting thicker in more recent years, has higher rates. It's incorporating that population surveillance, and also you're able to see how sharply that increase is being seen among different populations. So that's something that's available in our dashboard for all 100 counties in North Carolina, so that folks can see really what's going on in their own jurisdiction. And I'll just wrap up by saying that disseminating the data is so key. It's what moves data to action. This is a poster that we put together many years ago as we were first starting to do this work and stratify in this way. And someone saw this hanging in our office building, and they served on the North Carolina American Indian Health Board and asked us to come present. And that was really just by virtue of making this poster and hanging it up, that's how I got connected with Dr. Bell and the work that he's doing, and really kind of sparked this partnership in overdose work in our Indigenous populations. So I'm going to turn it back over to Dr. Bell to talk more about those collaborations.
Yes, thank you, Mary Beth. So next slide. So as Mary Beth mentioned, and as I mentioned at the very beginning, I chair the North Carolina American Indian Health Board. The American Indian Health Board in our state came into existence in 2009, largely as a result of efforts by our North Carolina Commission on Indian Affairs and our state Department of Health and Human Services. And our focus with the North Carolina American Indian Health Board is on research, education, and advocacy. And I want to just give a shout out to our program manager, Charlene Hunt, who is here in these photos, and she does a lot of work out in the community and traveling to different tribal events across our state. Next slide. And so, as Mary Beth mentioned, in our interactions in trying to get a handle on what the data was showing us with regard to the substance use deaths and hospitalizations, we wanted to make sure that we were appropriately responding to this issue. And so one of the things that we did as a part of an educational initiative, we developed an infographic looking at opioids in American Indians in North Carolina. We did this in partnership with the North Carolina Office of Minority Health and Health Disparities. Mr. Cornell Wright, who was the executive director at the time of the Office of Minority Health and Health Disparities, is a member of our American Indian Health Board. And so he was very much supportive of us doing this work, doing this this education in this area. And so this is one of a set of infographics that we did and having this specific focus. Next slide. We also have been able to utilize two really good resources in our state to try to get a good sense of what the health priorities are for tribes in North Carolina. So one of those is the 2018 tribal health assessment that was done by the Eastern Band of Cherokee Indians. This models the community health needs assessments that are done across the country, and it's a really nice resource to gauge what the community is understanding with regard to how they perceive some of the health challenges that they're facing. And then also our health board, in collaboration with the Maya Angelou Center for Health Equity, did a project entitled Native Pathways to Health. And that was done also in collaboration with the American Indian Center at UNC Chapel Hill, and was funded by grants from the Kate B. Reynolds Charitable Trust and the Blue Cross Blue Shield Foundation here in North Carolina. And that was an effort to work with the other tribes in the state. We conducted talking circles and gathered survey data to try to understand, again, so try to get a sense of what the health concerns, what the health needs are for the tribes in the state. And both of these resources are available online if you're interested in looking at them. Next slide. And so with this, the data that we looked at and the conversations that I had with Mary Beth and with Scott Probuchel, who's also in the Injury and Violence Prevention branch, we started strategizing a little more about how we might get tribal leadership involved in having discussions to look at ways to respond to the data that we were seeing. And we applied for a grant from the Council of State and Tribal Epidemiologists and received that grant and had a one-day state and tribal injury data sharing summit on June 29th in 2019 at the DHHS offices. Next slide. And we had representatives from across the state who participated. We had tribal leaders, we had representatives from the Commission on Indian Affairs, NCDHHS, obviously the American Indian Health Board, the Maya Angelou Center for Health Equity at Wake Forest. We also had the UNC American Indian Center. We also had faculty at the University of North Carolina at Pembroke, which is in the tribal homeland of the Lumbee tribe, and also had representatives from various tribal communities. So we had a really good turnout for this event, which we are very pleased with. Next slide. So these were our objectives, and I won't read each one of these out to you, but basically what we wanted to do is try to increase awareness of this issue, draw on existing resources that would allow us to develop a strategy moving forward, and then really encourage our tribal leaders to look at ways to make this data available to the community and how they might then develop strategies at the local level to address these issues. Next slide. So this was our agenda. So we had a welcoming and introduction, and one of our tribal members did a land blessing, and then we presented the data to the group that was there, that was present at the meeting, and then we had discussions about how we might move forward with trying to address some of these issues and how it's impacting our tribal communities. Next slide. And specifically, we wanted to come out of that meeting with action steps. So how would we best respond to what we see now, a sort of a data-driven approach to understanding how tribal communities might utilize the resources that they have available to address these issues. Next slide. So these were the action steps that we came up with. So we wanted the North Carolina Commission on Indian Affairs, which I didn't mention earlier, is in the State Department of Administration. So they play a very prominent role, and so we wanted them to establish data priorities and coordinate with NCDHS in implementing these policies, to obviously look at how Native culture and historical trauma and how the relationship to the land impacts health issues, to create a task force to continue this conversation. And so we had a really key set of action steps that were really driven by the conversations that we had during our session there. Next slide. So I'm going to turn it over now to Alyssa to talk about the Syringe Services Program.
Great, thank you so much, Dr. Bell. Hi everyone, my name is Alyssa Kitlis, and I am the lead for the North Carolina Safer Syringe Initiative, and I work in the same branch as Mary Beth. And I'm just going to take a few minutes to provide context about syringe service programs operating in North Carolina, and I'm really excited that after I share, we'll be hearing from Ginger about the program that operates in Eastern Band of Cherokee. So Mary Beth, would you mind going to the next slide? In North Carolina, syringe service programs or syringe exchanges, syringe access programs, needle exchanges, these programs have many names, but our law was passed in 2016. And the way our law is set up is that any governmental or non-governmental organization is able to establish a program if they have a core set of functions that they can guarantee. So one, the core one being that they can distribute and collect syringes and other safe injection equipment such as tourniquets, waters, and other supplies. Also, naloxone is a key piece of programs for the centering of overdose prevention in this work. Also providing information education on infectious disease prevention, as well as having a plan for how they can notify and work with law enforcement. And so in North Carolina, our law is considered a pretty low barrier law for programs getting set up and registering, because we really want to make sure that we can expand syringe access to people who use drugs and who need these services across the state. And with our law, programs that operate and register with the Division of Public Health receive immunity for their employees, volunteers, and participants. So that way, if they're found with the syringes or any of the other paraphernalia covered with the law, they are protected. Next slide, please. And I think a lot of people on this call know this, but just a reiteration that syringe service programs are really a critical way to reach people who use drugs and who are at risk of overdose in our communities. Not only do they really just distribute those supplies that are so central, they also are critical connections to care. They link people to treatment if they're interested. They link them to broader housing and healthcare. They also are community support systems. In North Carolina, a lot of our programs are even expanding to offer support around social determinants of health. So they're offering food, transportation, connecting people to housing, and are really just a critical low barrier access point for care. And the way our law is set up is that we oversee the program. So we register all the different programs operating in the state, but we also provide technical assistance and support because we know that communities and these programs need to establish in ways, we don't have like a standard approach that anyone needs to take. We really want them to set up based on what the community needs are. And so there are some programs that have a physical location where people can go to access services. There are also mobile or delivery-based services. There are programs that are operating within health systems or health clinics, within substance use treatment facilities or MOUD providers. And so really, we are not telling programs how to operate, but we're always here to offer support, connecting them to other programs, offering training around best practices, how to engage and support people who use drugs. And so we have a broad approach to how we are supporting these programs in our state. Next slide, please. And as of right now, we have 46 registered syringe service programs, which continues to grow throughout the 5 years since the law was passed. And a little over half of our counties are served by these programs. So we have 56 out of 100 counties that are reached in some way through these programs. And then we have one actual tribal program that we'll hear from Ginger talking about that. And we have programs that operate in areas where we know that our state recognized tribes are located, but we know that this is an area that we want to continue to grow and expand. And so I wanted to just share that one thing that we're doing with some COVID funding that we've received is we are actually investing in some of our partnerships with harm reduction organizations who have hired equity navigators who are focused on reaching people throughout the state who don't have access to harm reduction and overdose prevention. And one of those programs is focused in Robeson County and is working with a Lumbee tribal partner as well. And so we're hoping to continue to grow and expand and have Indigenous communities that need access to harm reduction, overdose prevention more formally reached as we expand access to these services in the state. Next slide, please. And this is a map of where the programs operate. And I shared this a little bit before, but in the bottom left-hand corner, you can see where all the programs operate. And this is really unique to North Carolina, and I think a really great opportunity because our programs are not just in the local health department or in a more clinical setting, but we actually have programs operating out of churches or faith-based organizations, in ambulances and in EMS and fire. And so we have a range of different opportunities for these services to get out to communities. And you can find the full list of the programs operating in the state in the bottom right-hand corner. That link is there. Next slide, please. And I just wanted to conclude by showing and reiterating how important these programs are and the work we're doing, particularly around overdose prevention and harm reduction. But in North Carolina, over the past 5 years, you can just see the continual expansion of access to services and the people reached through these programs. And so as of the last report, which covered 2020 to 2021, 26,596 individuals were served by these programs and over 80,000 contacts were made, which means different engagement, whether it's education, connecting to services, just having a conversation, providing supplies. So, upwards of 80,000 people or opportunities to connect with people and link them to care. Next slide, please. And this is my favorite slide because it really just shows how powerful these programs are. But in that same reporting year, over 8 million syringes were distributed and over 89,000 naloxone kits were distributed. And there were over 12,000 overdose reversals that were reported back to the programs that were connected with the services provided. So just really, this is such a critical part of our work. And we're thrilled that we have partners like Ginger that we get to work with to ensure that these services are reaching our Indigenous communities in North Carolina. So with that note, I'll turn it over to you, Ginger, to share about the great work that you're doing.
Thank you. Hello, everybody. My name is Ginger Southard, and I'm the manager of Zollie Public Health. We are a tribally operated public health program, which has a Syringe Services Program, harm reduction program embedded within it. We're located on the Kuala boundary in Western North Carolina. Next slide, please. This was a snapshot of what was on the division website about the program. It lists the services that we offer, the supplies that we offer, and it explains to the general public what the program is about. We had to do a lot of community outreach prior to opening, and we try to reiterate that education everywhere. So we have websites specifically for the program. This is the PHHS divisional website, which is in the process of being updated. But it shows a little bit about the supplies that we give, which are injection supplies. We give out biohazard boxes for syringe disposal, and we give those to people that need them that are diabetic as well. So we don't limit our services to only people who are injecting drugs. We try to incorporate the whole community to actually give them a sense of ownership in the program. Next slide, please. This was part of an article that was released after a year of us being in operation. That is where you see me standing. That's where we had our supplies set up, and that's how they are open. People come in, they get as much as they need of all of those supplies. We've got sterile water, tourniquets, condoms, crackers, water, cookers, cotton, anything that we thought they need. That's what we ordered. The only thing we do track are the amount of syringes that we give out per year, and we track what we get back. That red kiosk that you see in the bottom right-hand corner, those are placed throughout our community. We have 18 or 20 of them that are out, and they're just spread out all over the community. What those are used for is people can dispose of their syringe litter in those containers instead of throwing it on the ground or on the side of the road if they're getting pulled over. We tried to make them in high traffic areas where we knew people walked a lot. That was one of the goals of our program, and one of the promises we made to the community is that having this program would decrease the syringe litter. We were finding a lot of syringes in playgrounds and at cemeteries and behind community club buildings. So we promised to decrease that amount and to give people a safe place to dispose of it. We empty those containers once a week. We do track the amount of waste we get in there. We do it by a scale. We just weigh it, and we log that and report that at the end of the year. And people can use those that are not necessarily injecting drugs. We can put diabetic syringes in it. People that are taking testosterone shots and stuff like that at home, they put stuff like that in there too. So it's for the whole community. That's really what we wanted to do with the program, is give the community a sense of ownership in it. So we brought them in at the beginning. We talked to them about what we were going to be doing, where we were going to, we got their input on the location. Location was a hard part, but we did get input on it, and we just wanted everybody to own it, the whole community. Next slide, please. And this is another article. This one was in the CDC, and it's about the kiosks and what the program is doing. We have over 500 people enrolled in the program as individual users of the program. We do not limit enrollment to being EBCI enrolled. We do serve people that are not EBCI enrolled. However, we do track that. They are given ID cards with a combination of letters and numbers on there. And at the end of it, there's going to be an E if they're EBCI enrolled and an N if they're not. And that way we track how many enrolled members we have using it and how many non-enrolled members we have using it. And that helps us know where to focus our interventions and stuff. There's paperwork when people start the program. One of the questions asked on that paperwork is, what is the age of first substance use? And when that question is asked, we explain to the participant that we want to know what age they were when they first take their first drink of alcohol, smoked pot, or any type of substance. It's not just injection drug. And what we have found from that is people in our community have started drinking alcohol at very young ages. We had one lady that came in, and when she was 4 years old, she was given her first drink by her father. So that helps us see what kind of intervention we need and what age to start it. And it also helps us understand where the stigma is, because drinking does not seem to have as much stigma as injecting drugs, but you can end up with the same effect. There can still be trauma in the family. There can still be death. There can be arrests. There can be all of the same of the ripple effect, but the stigma at the cause of it is totally different. Next slide, please. This is showing our overdoses. Now, we have had an increase since COVID, everybody has. But if you'll notice on this slide, the months with the biggest spikes are November and December. Those are the holiday months, right? That's the months that we're mostly with family. Indigenous people are very close. They're usually very connected. They do a lot of family dinners and stuff together. But for this population who has burned some bridges and is ostracized just in general, they don't have that sense of connection. And this is just anecdotal. I don't have any data to prove that the overdoses go up in November and December related to depression or loneliness. But I feel like that's probably where those spikes are coming from. But if you'll notice, we're also seeing spikes in April and all the way around here. We're seeing a lot of fentanyl in our community. I don't know. I think that it's happening pretty much all over the country, but it's in marijuana now. I mean, it's saturating the community. And a lot of people do not understand the impact that fentanyl can have. We do provide education. We provide fentanyl test strips, but a lot of people think that they're just immune to it. And that is definitely part of the increase in our ebb and flow. We also get per cap checks, which are payments that come from our casino. We get those in December and we get them in June. And historically, we do see spikes in those months after those checks come. And that's just related to having more access to drugs, more money to buy stuff with. Next slide, please. So from, excuse me, from May of 21 to April of 30th of 22, on our boundary through our EMS system, we've had 87 overdoses reported. 13 of those have been fatal. 70 of those, Narcan was used or naloxone was used. That bottom half of that slide breaks it down to how the EMS, whatever investigation they did, it breaks it down to what was suspected with fentanyl, what wasn't, what they thought was cocaine, methamphetamine. But 13 deaths may not sound like a lot in a big city or anything like that, but in our community, we are so small that is an enormous number. And it is terrifying to think that that number could go up. COVID really impacted people's ability to get services everywhere, not just at harm reduction, everywhere. But when you're already marginalized, you're already ostracized, cutting out that ability to connect with somebody, to talk to them, to find out what's going on, it makes that whole experience much worse. It's almost like it's not ever going to end. And we've been in this for 2.5 years now, almost 3 years. And we are starting to, lift restrictions, but there's still, I truly believe that we have lost a lot of people just due to isolation because they could not cope with just being alone. And to numb that, their drug use increased. And then the introduction of fentanyl, which if you don't test for it, or if you're not intentionally buying it, you're not going to know it's there. Next slide. This slide breaks down the naloxone use or the Narcan use that was reported for overdoses. If you can look at that one that has, oh, are you there? Oh, goodness gracious. I'm sorry. We're having bad weather and my screen just went black. Can y'all hear me?
We can hear you.
Okay. All right. Okay. Sorry. If you'll look at the line that shows multiple doses, that total was 52 of those calls said they had multiple doses of naloxone administered. I was doing our Narcan report for the month of April, and there was one individual that responded to one reversal, one overdose, and gave 16 doses of Narcan to one person. to try to revive them. The person, according to the report, came back after the 16 doses and they never called EMS. We do tell people to call EMS anytime naloxone is administered, just because it's temporary, right? It depends on how much drug is in the system and how long the recovery part can last. But they gave this person 16 doses and still chose not to call EMS. But you can see, and so we know that they had to have fentanyl in it, right? I mean, if it didn't, there's something, they had some serious, something, I don't even know what it would be. So that had to have fentanyl in it. And that's one of the things that we are trying really hard to educate people on, is to use their fentanyl test strips when they're coming out of incarceration, or if they've been in the hospital. We tell them to cut their dose, whatever they're using, down at least in half, if not smaller, just to make sure that they know what they're getting and that they introduce it slowly back into their body if they're going to continue to use. Because coming straight out after going through withdrawal and being off of it for a period of time and going back to where you started, you will probably overdose. And that's what we're trying to prevent. Next slide, please. So this is one of my favorite slides, because we opened officially in 2018. I think the end of 2019, 2017, mid 2017, I was working out of a closet in our women's wellness building, but officially it opened 2018. So this is for Hep C cases. And this data comes from our hospital that's on the boundary, the Cherokee Indian Hospital Authority. You can see how the Hep C cases were rising and how they started coming down after the inception of the program. Now, there's a lot of other, interventions that were going on that came with the program. It's not only the harm reduction program that caused this, but I believe that it's like 90% the harm reduction program. It had to be. I just believe it with my whole heart. People were getting access to care. They were getting tested. They were, we just started interacting with people. And these programs are not just about giving out clean supplies. It's about connecting with people. And once you connect with them and you build a relationship, you can help integrate them back into healthcare. I know of 3 people that I sent straight to the ER from our program, and they all ended up in ICU with endocarditis. Had they not been able to at least talk to somebody who said, look, you don't look good. There's something wrong. You need to go get checked out. They may not have lived through that. So they're not just about the supplies. They're about the people. They're about connecting with them. You hear their story, and you hopefully can help them reintegrate back into the healthcare system. Next slide, please. This is what COVID did to our program. This building is the actual fixed site for our syringe program, and people are usually allowed in it. And all of the peer supports have the individual offices. They can sit and talk with people, and they have a private conversation, actually get into conversations about if they're doing sex work. Are they in a domestic violence situation? Do they need health care, anything like that? We had to move our services out to the front porch, and we had to separate things out like this. So the table where the 2 chairs are, that is where the peer support people were working from. And the participants had to stand behind the 3 chairs. That was 6 feet down. So they had to yell these questions back and forth. Have you been tested for Hep C? Have you been tested for HIV? Are you in a domestic violence situation? And when you're yelling these things back and forth, you're not going to get accurate answers, because nobody wants their business everywhere. It limited the amount of people that would come. And our hours were scaled down just to meet the CDC requirements and not to have as many people there. So it really truly affected the services, and it affected the participants. It was not good at all. We lost a lot of people from the program during this. They just disengaged from it. We're slowly trying to reach out to them and get them back. We have a mobile unit that goes out, and we're looking for places where we can set up where there's a lot of foot traffic. And we hope to get those people back into the program. But this is what COVID did. We worked around it, and we did the best we could. But this is this is part of it. Next slide. Oh, I think that's it. Sorry. Well, that was it for me. If y'all have any questions or anything, just let me know. And thank you.
There is a question in the chat. The statewide data include the specific tribal membership. Mary Beth, I don't know if you want to try to answer that.
Yeah, it doesn't, and that's feedback that we have gotten from that data summit that Dr. Bell shared about, and since then, feedback that it's really crucial for our Indigenous populations in the state to know how the different tribes are impacted. And so we've done some work around like looking at the counties where the overdoses are occurring, and you know, the traditional lands and which tribes are residing in those counties, but we don't really have great data actually on death certificates or the hospital or ED data that speak to tribal affiliation. And so this is kind of an ongoing conversation that we've been having with CDC and partners in other states and Dr. Bell, trying to think of ways that we could creatively get those tribal specific rates. And it's challenging in North Carolina. We talked to a lot of, or I've talked to a lot of partners, epidemiologists in other states where they have their entire state is federally recognized tribes, and they just have a lot better data supports and federal funding to collect those data at a tribal level. They have the support of like the tribal epicenters, and because we only have one federally recognized tribe in North Carolina, it's a lot different for us.
I will say that the state did a really nice job with COVID vaccinations of trying to estimate tribally specific vaccination rates by looking at kind of roughly where people lived and where the vaccinations were occurring. Obviously, that doesn't take into consideration if someone has moved from their tribal homeland to another area. But that is at least one attempt that the state has tried to make to look at tribal specific data. And then China, somebody asked if the recording will be and the slides will be made available afterwards.
Yes, I'm going to be posting the recording on our webpage, and I can link it, and you guys can just check back in the next day or two, and it should be up. And then if you guys are okay with me posting the slides, I can do that as well. Okay, thank you, Mary Beth. Okay. If anyone else has any more questions, you can feel free to put those in the chat or the Q&A, or if you're feeling very talkative today, you can raise your hand and we can unmute you. I'm not seeing any questions at the moment, but I did want to say thank you guys for such an informative presentation. I know I wrote down a lot of questions, and then a minute or two later, you guys would answer it. So I think you guys did a really awesome job at explaining everything and going through all of the data. It was really helpful for me, especially because I do work on some opioid grants. So I'm definitely going to try to use some of this data a little bit later in my work. And then we just have some kudos in the chat box, everyone saying thank you and that they enjoyed the presentation. And then our HCC is working in Robeson County and the Columbus County. Oh, very cool. Thank you for sharing that, Andrea.
Yeah, that's RHCC is Robeson Healthcare Corporation, which is a federally qualified health center. So they're doing very, very important work. And the Lumbee tribe they've just recently started about a year ago, I guess, an MAT program. So I think they're challenged with continuing funding with that right now.
It does look like we have a question in the Q&A box. They say, firstly, thank you so much for your presentations. Trying to reach AIA and BIPOC folks has been a focus of mine when doing outreach. I work predominantly in Alamance County region. Do you happen to have any suggestions or ideas?
For us, we have our own epidemiologist embedded into our Public Health and Human Services division. And that's how we get a lot of our community specific data is through him. There should be some contact information on the PHHS website. You could try to contact, if you're looking specific for Indigenous information for us, that would be the best way to get it. That's where most of ours is kept.
And if you're working in the Alamance County region, I would say reach out to the tribal leadership for the Occaneechi Band of Saponi Nation. They're based there, I guess, just north of Burlington in Alamance County. So that would be I think the best way to engage that community.
Yeah,
Or
and
if you reach out to me, I can help with that as well. But
yeah, I think that's a great point, Dr. Bell. And I wanted to mention, we also, as I shared earlier, we're working with 3 Syringe Service Programs in the state to focus on equity navigation. And what that looks like is hiring individuals from the historically marginalized populations that they are focusing on. And so in Robeson County, that does include the Lumbee tribe, but then in those other counties, it's Guilford, so it's surrounding Alamance. And so we could also connect you with some of our partners there who are doing that work. And so I can put my email in the chat if you wanted to follow up as well. And yeah, I think just reaching out and we can connect you to the folks doing that work because it's such an important piece. And we know one of the biggest challenges in harm reduction organizations is that a lot of people don't connect or recognize themselves in the program. So we're really trying to figure out ways we can continue to expand and make sure that people can see themselves and have their community centered in that work. So connect with us and we'd love to continue that conversation.
Looks like we have another question. Someone asked, what avenues are possible to take in attaining Native American tribe demographics within death certificate data, if there are any that are known so far?
For us, it's going to be the same thing. We are currently trying to go through death certificates in the counties and work to identify Indigenous people through those death certificates that might not have come through the Cherokee system. But our epidemiologists, they have been working on that for probably 2 years now, trying to get everything straightened out. But that's really the only thing I can say is to contact, each tribe, and they might have their own system. I don't know if it's through the state or not.
You can reach out to state level epidemiologists as well. So we have, I get a monthly update of the statewide death certificate file. It's not always reliably reported. It's depending like who's filling out the death certificate data. And sometimes I think it's better in death certificate data, but we have a real problem with race misclassification in our emergency department settings and trying to do any sort of breakdown by race ethnicity and the ED data, because oftentimes, the ED doctors are focused on treating the patient in front of them and saving their life and not so focused on filling out paperwork accurately or asking someone how they identify. And if you're incapacitated and not able to fill that paperwork out for yourself, then it could be just based on, does your name sound one way or the other? Do you look one way or the other? And so the data just aren't as reliable in an ED setting. And unfortunately, I think that happens sometimes too in our death certificates and other vital statistics, though there are efforts, I think, to make it better.
Thank you for answering that. We have another question in the chat. It reads, we have patients who receive treatment at startbuke.com and do not want tribal leadership to know that they're in treatment. Do you have any suggestions or peer support groups that we could refer them to?
Is that it? That might be a Ginger question.
Well, I honestly, I don't know. I've never run across, our system is anonymous when they go through our MAT program. So I don't know that it doesn't actually get reported to our tribal leadership who's in that program. And I'm not really sure. We have peer supports that work at our syringe program. If it's a different tribe or different location and they want to connect with just a peer support, somebody to talk to, then they can absolutely call our program and talk to a peer support. And they could, that if they wanted to do that, I can give you that number. And it would be somebody they could talk to. But as far as knowing of like any support or anything like that, I just know of the groups that we have here on the boundary. Do you want that number for our program that they could maybe just call and talk? I'll type it in the chat, and that way if you want it, you can get it.
Thank you, Ginger. And again, I posted in the chat, I will be posting the recordings and the slides to this on our NIHP webpage. Just give me about a day or two to get that uploaded. But I did link the page where it will be found. So you can check that out. Maybe Tuesday it should be uploaded since Monday is a holiday. And I don't see any further questions. I did just want to say thank you again. We are at time. So thank you guys so much for this wonderful presentation. I learned so much, and it seems like the attendees did as well. So I will go ahead and stop the recording.